Good evening, Pure FB viewers. Welcome you all for today's session. I am Dr. Hemnath, consultant urologist at Preeti Hospital. So, currently the hottest thing in urology is robotic surgery. All the young urologists would aspire to become a robotic surgeon. And one of the toughest surgery through any means in urology is radical cystectomy with lymphadenectomy, along with an intracorporeal diversion, urinary diversion. So definitely robotic platform has added a advantage over the open and the laparoscopic surgery in this specific difficult surgery. And to tell you about more of this, today we are having renowned robotic surgeon from Tamil Nadu, Dr. Manikandan. So I will. Good evening, sir. Thank you for joining us today. Can you hear us, sir?
Good evening, Dr. Hemnath. Thank you. Thank you for inviting me for this session.
Yes, sir. So, how did you start this career in robotic surgery, sir? We would like you to tell us about your career. Where did you do your PG, and where did you train yourself in robotic? Who is your mentor? Please tell us about this, sir.
So I did my urology training at JIPMER Pondicherry. Then I continued working there as a faculty member. In 2017, 16, late 17, JIPMER got the robot. Okay. We had the X-ray system got installed. So then we started doing reconstructive surgeries and ablative surgeries. As we gained experience, then we moved on to partial nephrectomy and cystectomies early. Cystectomies was initially the excision part was robotic, and the urinary diversion we did extracorporeally. Okay. We being a peripheral center, we are not getting much prostate cancers, so we wanted to focus on bladder cancers because the bladder cancer volume was very large. So down the line, we attended a few meetings. I attended the Henry Ford Hospital with Professor Manikandan, learned and about techniques of cystectomy and prostatectomy. Prostatectomy helps in intracorporeal diversion as well. Okay. The most important aspect was that Dr. Manikandan from Miami Cancer Institute visited our place and mentored us and doing intracorporeal diversion. So we are very grateful for him for having come down and helped us in taking this program forward.
Okay. Mostly you started by yourself, and you got training for this by seeing others, and you got expertise in this. Hello. Hello. Can you hear us, sir? Hello. Can you hear us, sir? So, hello. Meanwhile, I'll introduce Dr. Hello. Can you hear us, sir? You are muted, sir.
Please go ahead, please.
Muted. Yes, sir. Yeah. So, how was your transition, sir? Either it is from open surgery to robotic, or open lap and then to robo?
Yeah, we in 2007, 8, 9, we were doing predominantly open surgeries. Then we slowly transitioned from open to laparoscopic, and from there we moved on to robotic. I think that is the usual way in the previous generation. Not your age group. Your age group can directly transform from open to robotic surgeries.
No, sir. I am also going the traditional way, but still not trained in robo. But we are doing laparoscopic surgeries. Okay. So let me introduce you.
Big difference moving from a laparoscopic to robotic platform.
Okay.
A couple of few cases, then you should be able to master the technique.
Okay, sir. So I'll share my screen about your introduction, sir. So let me take few minutes in introducing you. So Dr. Manikandan is a senior consultant and director, Department of Urology, Miyot Hospitals, Chennai. He is the first person to start robotic surgery at JIPMER in 2017. He has performed more than 250 robotic procedures, including complex procedures like robotic radical cystectomy with intracorporeal orthotopic neobladder. He is a member of committee nominated by Ministry of Health and Welfare, Government of India for inspection of renal transplant centers. He got the best poster prize, Tapasukan 2020. He is a peer reviewer in IJMR, BMG, IJPP, and open journals of clinical case reports, Indian Journal of Cancer, Indian Journal of Urology, and Journal of Urology. He has also performed more than 300 successful kidney transplant surgeries. He published more than 78 papers and 3 book chapters. So over to you, sir. You can share your screen now.
Thank you, Dr. Hemnath. Are you able to see my presentation? Are you able to see my presentation?
It's clear. You can go ahead, sir.
Thank you. So I would like to put on record my thanks to Dr. Chandramohan Vaddi, Managing Director of Preeti Urology Hospitals at Hyderabad, and Secretary-elect Association of Southern Urologists for giving this opportunity, this academic forum. So today we will talk about a robotic radical cystoprostatectomy. Myself, Dr. Manikandan from Chennai. So the core principles of this topic will be based on the principles of minimal invasive surgery for radical cystectomy, the surgical anatomy associated with the minimal invasive cystectomy, patient positioning system, and trocar placement, the key surgical steps, complications expected in robotic cystectomy, intracorporeal diversion, the oncological outcomes, and always the Achilles heel is comparison with the open radical cystectomy, which has been the gold standard for more than 4 decades. And a few words about the learning curve associated with this complex surgery. So the most important thing when transition from open to minimal invasive surgery in bladder surgery is the oncological safety. We don't want local recurrence or a port-state recurrence or a peritoneal carcinomatosis when we are doing a bladder cancer surgery, because that will be detrimental. And we have a well-established open surgery which has stood the test of time. So the main important principle in the robotic surgery is to avoid urothelial cell seeding when you are performing the cystectomy. Perform a meticulous lymph node dissection as equivalent to an open surgery, and we keep the bladder suspended to the anterior abdominal wall till almost the posterior and lateral dissection is completed, and then finally we drop the bladder down for the anterior apical dissection. A careful handling of the ureter, avoid electrocautery close to the ureters. Always dissect the ureters with the tunica adventitia surrounding it, the adventitial layers. So this will help in preserving the vasculature of the ureters, because we are going to reconstruct the ureters, and nerve sparing where appropriate. So this slide will look at the surgical anatomy. Basically, we are talking only about the male cystectomy today. So the important landmarks will be the superiorly the peritoneal coverings and the bowel. When you look at the transperitoneal plane, the infralateral borders will be the muscles, the levator tendinae and the obturator internal muscles. The posterior is the most important structures is the peritoneal reflection, the cul-de-sac and the rectum, sigma rectum, and anteriorly the bony structures. This is space of reticulus and the pubic bone. So this is the landmark which you'll see once the port is inserted and we insert the camera. The bladder is seen in the center of the field, and on either side will be the umbilical arteries. Then we look at the lateral landmarks, the ureters, genitofemoral nerve, and the posterior and the inferior landmarks would be the obturator vessels, and superiorly the urachal remnants. So the pelvic plexus, the pelvic autonomic plexus is very important when you are planning for a nerve sparing cystectomy. So this is similar to this anatomical distribution as we look in radical prostatectomy. So there are nerves which are coursing the tip of the seminal vesicles as well as in the dorsolateral aspects of the prostate. So these nerves, as far as possible, needs to be preserved if you are doing a neobladder and if you are planning for a nerve sparing cystectomy. So when we have an ideal candidate that's nearly disease, when the planes are good and we have an younger patient, then as far as possible, you attempt a nerve sparing at least on one side. So the patient positioning, as the patient is wheeled in the ward, patient is placed in a steep Trendelenburg position, and the legs are supported in Allen stirrups. And after that, we place the primary port, the camera port, which is placed in the supraumbilical position, about 3 to 4 centimeters, depending upon the abdominal body habitus of each patient. Then we have placed the other 3 robotic ports, and we have an assistant port, a 15 mm port, which can be either on the right or left side of the abdomen. Depends upon the surgeon's preference. Some surgeons prefer to have the 2 assistant ports on the same side, but I like to put the 15 mm port on the left side and a 10 mm or a 5 mm port on the left side. So the 15 mm can be used for bringing the staplers or a hemorrhoid clip player, and the 5 mm port or 10 mm port can be used for the robotic suction or using a laparoscopic hand instruments for retraction, holding, and countertraction. The steps of cystectomy are very standard. The steps are first identification and dissection of the ureters. You dissect the ureters along with this vascularity up to the vesicular junction and disconnect the ureters. Then we make an incision in the cul-de-sac and dissect up to the apex of the prostate. Then we define the tissue on lateral to the bladder, away from the bony landmarks, and so the dorsolateral pedicle stands out, and divide the vascular pedicles either using a stapler or a hemorrhoid or a vessel sealing instruments, depending on the availability and surgeon's preference. Once this is done, then we'll drop the bladder, divide the dorsal venous complex, and complete the apical dissection. So after that, we do the standard lymphadenectomy, up to the aortic bifurcation, is involving the common iliac, external, internal iliac, obturator, and the presacral lymph nodes. So lymphadenectomy is a very important integral part of the cystectomy. So that has to be meticulously performed to reduce the chance of local recurrence. So this is a short video of a cystectomy part. So first you identify the left ureter and trace it close to vesicular junction and divide the ureters. The clips are attached or tied with the silk sutures. This will help later in our reconstruction. So similar procedure is done on the right side. So once the ureters are divided, the posterior dissection is completed. So once the posterior dissection is completed, then we make this space. This is a very important step. Make the space between the lateral wall of the bladder up to the bony landmarks. We see the levator muscles. Then we divide the pedicles using a stapler.
Have you did you optimize your videos? It's a little bit of it is playing not playing smoothly.
It's going fast.
No, it's not moving smoothly. There is breaks in between.
Okay.
If you are not optimized, then you can close it and again optimize and then restart, sir.
Okay. To me, it looks good. I don't know.
For you, for us, it is a little.
Shaking, is it?
You can close it and again stop sharing and then again restart after optimizing, sir.
Now is better? Is it better now?
Little better, sir.
Okay. So, as I said, the ureters are dissected, and then the ureters are clipped at the keeping the hemlock sutures, hemlock clip attached to the sutures. We come do the posterior dissection up to the as far as inferior left to the prostate. Then we create a space on the lateral wall of the bladder away from the bony landmarks. All the soft tissues taken on the bladder side, and that defines the lateral pedicle. So then we divide the lateral pedicles either using a hemlock or a vascular stapler or a vessel sealing device. So then we do the bladder drop, similar to prostatectomy. After the bladder drop, the fourth arm is very crucial now. We pull the bladder up and define the apex of the prostate. So now the nostril vein complex is sutured. So then we divide the apex of the prostate. This is very important to maintain the urethral length. So when you want to do the neobladder, this
We're not hearing your voice, sir. You are muted. Network problem.
can you see my slide?
Yes, sir.
Yeah. So once the cystectomy is done and the perfect hemosis is obtained, now the next, the most important technique, the part comes in this urinary diversion. Traditionally, to start with, people were doing extracorporeal urinary diversion to save time as well as to reduce the fatigue factor. As people gained experience in robotic techniques, then now more and more centers are doing intracorporeal urinary diversion. So you decide upon the urinary diversion based upon the very important factors with the this is a slide which shows that the how the number of urinary diversions the intracorporeal has increased as time has gone by, starting from early 2004-5 till 2020. So now more and more centers are doing intracorporeal urinary diversions. So urinary diversions, the type of diversion is decided by the location, extent, and histology of the tumors. So in a male, if you have a prostatic stromal involvement, then we will not do a neobladder. We would like to do a intracorporeal ileal conduit. Particularly in the females, if there's a tumor involving the bladder neck, then we avoid intracorporeal neobladders. We don't want to do a neobladder in patients above 65-70 years age. The performance rate is very important. The comorbidities and patient preference, as well as the most important thing is the surgeon experience and the experience of your assistant and the hospital setup. So when you're doing a neobladder, the very important thing is the dissection of the apex of the prostate, and maintain as much as length of the intra-abdominal part of the urethra, which will help in the continence later. So this is the most important stuff, that the length of the urethra and the raptor sphincter has to be maintained for a better continence outcomes. So most of the centers worldwide does the modification of the Studer's ileal neobladder and based on the modifications which has been described by Peter Wiklund from the Karolinska University. So that is the most common neobladder done worldwide, open surgery, and people replicated the same thing in robotic surgery as well. There are people who are doing other types of diversion, like Hartmann's pouch or a Padua pouch. It's always better to do a simpler and same bowel reconstruction modification pouch again and again to reduce the complications associated with it. So we do the ileal Studer's pouch, isolating about a 54 centimeter of a small bowel, about 20 to 25 centimeter and proximal to the IC junction. Once the bowel segments are marked, they are isolated and divided on laparoscopic intracorporeal technique by using the bowel staplers, and the stapled bowel segments are then reanastomosed to ensure the bowel continuity. So once the bowel resection is done and the segment is isolated, the part of the small bowel which comes fully to the pelvis is chosen, and then it is brought and fixed to the pelvis by using a small 30 Vesical or a 30 V-lock sutures to the pelvis, and then enterotomy is made, and the uretero-neobladder anastomosis performed. So this is slightly different from the open technique, where the uretero-vesical anastomosis, the last step, is performed after you implant the ureters. But here, for ease of doing the surgery, the uretero-vesical anastomosis is performed first, so the whole complex remains stable. After that, the ureters are reimplanted. The bowel is reconfigured, and the ureters are reimplanted in the chimney of the neobladder. So sometimes it's the small bowel may be tethered and find difficult to move down. In that case, you have to release the adhesions, make small incision in the dysentery. These are all maneuvers which will help in bringing the small bowel to the pelvis. So once the neo-urethral anastomosis is performed, then we detubulate the bowel and reconfigure the bowel to achieve as much as a spherical shape as possible, to reduce the the bowel contractions, as well as to have a low pressure reservoir. This is very critical to improve the continence and to avoid incontinence episodes in the patients, as well as to protect the upper tracts. So once the pouch is created, then the ureters are anastomosed to the chimney separately in a Bricker fashion over a stent. is a short video where we have divided the bowels, and the bowel segments continuity is maintained by a stapler anastomosis. So this is what I was telling you, that the small bowel part which comes freely to the pelvis is brought down, fixed to the pelvis, and then the anastomosis is performed, similar to the anastomosis of a radical prostatectomy. So if you do an open surgery, seeing this kind of anastomosis is very, very difficult. So most of the time it is we take a 6 or 7 sutures and we bring it down anastomosis to the urethra blindly. But here, because of the robotic vision, it's very clear and easy to see the anastomosis. Once the neourethral anastomosis is done, then the small bowel is detubularized. Then the posterior plate is anastomosed. After that, the bladder is folded, the anterior layer is folded, and then the anterior layer is closed. After that, the ureteroenteric anastomosis is performed. The anastomosis is stented with a ureteric catheter, and then the ureteric catheter is then exteriorized. There are centers who are perform this anastomosis over a stent, leave the stent in the neobladder, and then remove it later. Allow all the urine to enter the neobladder, but we prefer that the stents are externalized to reduce the urinary leakage in the early postoperative period. So complications, the intra and the perioperative period, the complication will be the bleeding. One, if the if the pedicles are not taken care of appropriately, so care must be taken to divide the pedicles either over clips, or when you are using the vessel sealers, make sure that the hemosis is obtained very carefully. Avoid rectal injuries. Particularly case selection is very important in the early learning curve. Try to do, should not attempt a case which is locally advanced like a T3B tumors. Try to start the case using an early stage T1 or T2 cancers. And urinary leakage. Urinary leakage can be due to either devascularized of the terminal part of the ureters, or it can be a leakage from the ureteroenteric anastomotic site. So having a splint like a ureteric catheter or a stent helps in reducing the urine leakage, and attention has to be focused on doing this the anastomosis, the ureteroenteric anastomosis, to avoid ischemia as well as tension in the ureteroenteric anastomosis. Always bring the bowel segment close to the ureteric side than the ureter close to the bowel segment when doing the ureteroenteric anastomosis. And care should be taken when you are moving the left ureter under the sigmoid to bring it on the right side of the sigmoid colon. So you should have a wider window to avoid compression and ureteric obstructions. Bowel leaks can happen, particularly when you are doing when care is not taken to close the corners of the staple bowel anastomosis. So that is very important. Paralytic ileus is a very common complication after cystectomy, both in open as well as in robotic surgeries. So reduced bowel handling, reduce intraoperative fluid administration, and following the RAS protocols greatly reduces the incidence of paralytic ileus. The most important thing is the which is not talked about in many forums is the side effects of the pneumoperitoneum, particularly when the patient is in a steep terminal position. When you're in the learning curve, you are doing cystectomy for 7 hours, 8 hours together. So it causes severe effects on the patient's hemodynamics. So that has to be taken care. So in the early part of the surgery, when after the cystectomy, the telomere portion can be corrected, and the bowel intracorporeal bowel diversion can be done in a slightly Trendelenburg position, and take off the pneumo for some period of time to give to reduce the intraabdominal pressure. So these things will help in reducing the complication related to pneumoperitoneum during the early part of the learning curve. And DVT, so DVT prophylaxis are very important because these patients are in the early surgery are going to be on the operations table for a long period of times. So the most important concerns with the robotic cystectomy is the local recurrence. Is it more than the open surgery? Port site recurrence and peritoneal carcinomatosis, because we are dealing with the transitional cancers. What about the high-grade complications? And very important in our setting is the cost. So initially, the International Robotic Consortium group, they looked at the retrospective data of complications, the local recurrence rate with cystectomy of robotic cystectomy compared with open cystectomy. And then they found that the primary disease stage, that is the T stage, the lymph node status, was the most important parameters for local recurrence rather than the robotic approach. That was their conclusion, though it was a retrospective study. So then to identify the problems, the Dr. Deepan Parekh from Miami did the randomized study, first study in the robotic assisted cystectomy series, where the cystectomy was done at robotically at multiple centers in the US. And the urinary diversion was extracorporeal, because not all the centers were doing intracorporeal urinary diversion. So to standardize that, they looked at the cystectomy data. The primary endpoint was a 2-year progression-free survival, and it was almost equal in the both arms. This is the robotic as well as the open cystectomy group. So the non-inferiority of robotic cystectomy was proved by this randomized trial, and more centers started performing robotic cystectomy after this publication. So next, there was a systematic review of comparing the robotic with the open surgery. This also had looked at the 5 randomized control trials involving 540 patients. There was no difference in the disease progression, major complications, and quality of life between the open and the robotic group. And robotic cystectomy was associated with lower blood transfusions, shorter hospital stay. Probably there was less incidence of wound infections, and but there was a long operative time. And the local recurrence rate was similar in both the groups. So the Cochrane review also concluded the same, that the robotic group cystectomy group was comparable to open surgery with respect to the local recurrence rate or the complication rate, with a slightly lower transfusion rate and a shorter hospital stay. But there was a heterogeneity in the data of cystectomy, because there was many centers were doing extracorporeal diversion and few centers were doing intracorporeal diversion. So to look into it, this publication looked at the complication rate as well as the intraoperative time. Definitely centers which are doing intracorporeal urinary diversion had prolonged operating times and higher complication rates compared to extracorporeal group, but not high-grade complications. But we have to look at that the centers which had fewer complications were high volume centers and were doing cystectomy for a longer duration of times. But an average center still has higher operating times with respect to intracorporeal diversion. So this was a recent publication from the NHS. They looked at the morbidity of robotic cystectomy with open cystectomy. The primary outcome was the number of days alive and out of hospital for within the first 90 days after comparing a robotic group with the open radical cystectomy. 338 patients were eligible to be included in the study, and 156 patients underwent robotic surgery, and 149 patients underwent open surgery. They found that in the robotic group, patients stayed slightly lesser in the hospital compared to the open cystectomy, and the complication rates were slightly lower than the open group, particularly the wound infection as well as the thromboembolic complication. Rest didn't reach a statistical significance. So more and more centers are doing robotic cystectomy. As people gain experience, the complication rates also has come down. So the most important thing is, does the cystectomy, robotic cystectomy is safer in terms of recurrence and survival outcomes. So this was a retrospective study which published in 21, where 2,000 patients who underwent robotic surgery were analyzed regarding their oncological failures within 3 months. About 4% had a local recurrence rate, abdominal wall metastasis about 1.2%, and peritoneal carcinomas were 1.2%. Finally, the multivariate analysis suggested that the disease stage is a most important determinant for relapse or unsurvival rather than the technique, the minimal invasive technique. And these results were comparable with the historical open surgeries. So the next thing is important thing is the nerve sparing. If you look at this paper, if you do an incremental nerve sparing, the results are better. Long-term continence rates are better in patients who are bilateral nerve sparing compared to a unilateral nerve sparing or a no nerve sparing approach. So in young patients who are opting for an orthotopic neobladder, it's always, if feasible, perform on nerve sparing at least on one side. And finally, so how many cases a center must do to reduce the complication rate? This is the most important question. This publication looked at the number of patients to be operated in a center to reduce the complication rate. That's the they looked at the 90 days major complication rates. They said that 137 conceived cases need to be done by a team to reach the meaningful complication rates to reduce to make it safer for the patients. But most of the centers worldwide may not have the numbers to reach this status. So the AUA recommendation says that at least the center should be performing about 20 cases per year consecutively to maintain the learning curve, to train the team members, and doing a robotic cystectomy with the intracorporeal urinary diversion. So other option is to have two team approach. One team can do the cystectomy part and the second team can do the diversion part. This also help the keep everybody get trained and keep in touch with the robotics techniques. So finally, to conclude, robotic cystectomy is a complex surgical procedure. Multiple surgical steps are there in this surgery that needs to be standardized by the team members to reduce the complication rates. Definitely, robotic cystectomy, after you cross the learning curve, has lower complication rates than open radical cystectomy. It has been proved oncologically safe. No increased risk of tumor seeding. It is an expensive technique, definitely. Particularly in a developing country like us, it costs a lot of money to the hospital, to the patient. So, but hopefully the technical advances will reduce the cost in the long run. Another note of caution is that the better outcomes which has been reported in literature are coming from few high volume centers worldwide. So when you're starting the robotic cystectomy program, be cautious, particularly when your case volume is not great. And we need a dedicated team for optimal outcomes, particularly when you're doing an intracorporeal urinary diversion. Thank you.
Thank you, sir, for your wonderful presentation. A few discussion points. Sir, after doing open laparoscopy and then going to robotic, where do you feel that, which are the steps you feel that robotic has a definite advantage in radical cystectomy?
And robotic, if you're using the vessel sealer or the clips, the vision is so great. The blood loss is very minimal, and the pneumoperitoneum also helps greatly in this. And the apical dissection is very meticulous. You can have a preserve the membranous urethra length, so that helps in neobladder reconstruction, makes it easier. The vision is a great thing, particularly when you are operating the pelvis. That's a more advantage in robotic surgery.
Okay, sir. Sir, what is your post-operative follow-up, sir? Management, what is the course you follow? Drains, when do you remove catheter, CIC? Or how do you follow up your patients, sir?
We
In the hospital.
we remove the nested gastric tube once the patient is outside the operating room, and we start orals as early as possible within 6 hours. So when some patients after 48 hours they develop paralytic alias, definitely. So in those situations we withhold the fluids. In case if there is a gaseous distension, we insert rails tube once, empty the stomach, and then restart the fluid as early as possible. That helps in the recovery. Also, the patient is not confined to the bed. He takes orals and starts moving. The splints we remove on 6th or 7th day. And if you are having a neobladder, we do a cystogram, and then we pass hours, and then we remove it at 2 to 3 weeks.
Okay, sir. In your clinical practice, how often you give patients the neoadjuvant chemotherapy before taking up for cystectomy, sir? Or do you follow the routine?
When the institution previously working, the majority of people used to get a neoadjuvant chemotherapy, but in private, it's very difficult. Yeah, exactly. So yeah, that is a very the Achilles heel that we advise the patient for
the patient don't turn up for cystectomy after neoadjuvant.
Absolutely.
Yes, sir.
Yeah, you're right. So they spend the money in chemotherapy, and then they don't come for cystectomy. Yes. And then they come after 1 year, 2 years later with recurrent growth, and spend all the money. So that is a very important thing. You have to balance the both. You have to optimally choose patients who will be able to afford neoadjuvant chemotherapy and come for cystectomy.
Yes, sir. So in your practice, how do you choose patients for orthotopic neobladder, sir?
Patients, most important is the pre-op discussion with the patient. For a well-motivated patients below 65 years who are commitment for follow-up. Because after that, these patients may develop hyperkalemic metabolic acidosis, may develop urinary tract infection. So these patients need to be ready to come for follow-up. The pre-op counseling will help you in deciding which patients. If you patients think the patients may not come for follow-up, it's better to do a ileal conduit diversion rather than doing a neobladder and have follow-up issues later.
Okay, sir. Okay, sir. Thank you so much for joining us, sir. Once again, thank you for your time with us. It was a nice presentation, sir. It was a learning experience for all of us. Thank you, sir. Thank you so much.
Thank you, Dr. Emrat. Thank you. Convey my regards to Dr. Chandrapur for giving me this.
Sure, sir.
Thank you
so much, sir. Thank you.